All right, everyone, welcome to another episode of What's What BR. Today we have Dr. Emily Cassidy with us. How are you?
Doing great, thanks.
Well, I appreciate you taking time. There is, especially in the medical field, it's hard to get time sometimes these days. Make it a little time for us to talk to us.
No, it's a pleasure. Thanks for having me.
So I'll let you do it. For anybody who doesn't know, kind of what is it that you do? Kind of what's the daily, job for Dr. Emily Cassidy? What do you?
Sure. So I'm a thoracic surgeon. Most people have no idea what that means. It means surgeries within the chest cavity. Predominantly, it's lung and esophagus surgery. My specialty, my sort of day to day, I really have a strong focus on lung cancer. That's always been a passion of mine. So I would say the majority of my cases are focused on lung cancers.
Gotcha. And you're at the lake, correct?
I'm at Our Lady of the Lake. Yep. We operate almost every day here, Monday through Friday. So a typical day in the OR gets started around 7 a.m. And we'll do anywhere from, 2 to sometimes 4 or 5 cases per day. In between, we see patients in the clinic and patients in the office. There are obviously a lot of other diseases within the chest that are treated by thoracic surgeons. But like I said, for me specifically, I would say the bulk of my practice is related to lung cancer.
Okay. Well, it is also Cancer Awareness Month, right? That's where we're at, today. So that's one of the reasons we wanted to kind of have you come talk and goes on. I always find it funny. We have these months for things like we only need to worry about lung cancer during the month of November. No,
definitely need to worry about it all the time. I think it's always good to raise awareness, and by having a month assigned, it kind of, gets us plugged in with people like you to help get the good word out there. But I do think Lung Cancer Awareness Month is, of all of the disease awareness months, it flies sort of under the radar. Our color is white.
No.
It's like if I'm wearing a white shirt, nobody knows I'm representing.
I'm going to say something that sounds really horrible, but it's like my mind went, they need the marketing team back on this, because I immediately think white, like the surrender flag. And if you've got lung cancer, you don't surrender here. You need to, you don't go wave your white flag.
I agree. But, like when NFL players wear white socks, we're not really raising any awareness that way, are we?
Right. Hey, are they doing, is that for lung cancer? Was that for us, or is that just was the guy felt like, wearing the white socks? Which one was it? So, or I guess maybe you could market it and spin it and say that it's, with football, they always are trying to raise awareness with the white socks.
That would be a more glass half full way to look at it. You're correct.
So tell me, what is, if there's symptoms somebody should be looking for, kind of walk me through, kind of risk factor symptomatic, what is it?
Yeah.
I can't imagine somebody just wakes up one day and is like, I think I've got lung cancer, and then rolls into the ER. It seems like this would be one of those, you thought you had something and turns out, unfortunately, it was this.
So yes and no. I think there are kind of 2 broad groups of lung cancer patients, right? Typically, the group that's in the earlier stages of lung cancer, they are completely asymptomatic. There are certainly risk factors, there's obviously cigarette smoking, secondhand smoke, environmental exposures, family history, things along those lines. And that affects all of us to some extent. But I think what's tricky about lung cancer as compared to maybe some other cancers is that when it's in its early stages, it is almost always asymptomatic. So if you sort of wait for those symptoms to develop before looking for it, it's advanced at that point. The symptoms are usually more related to progression. So those patients will present with, cough, chest pain, shortness of breath, but that's typically indicative that a lung cancer has progressed to an advanced stage. So, at that point, surgical options aren't there's not much we can do to surgically remove an advanced cancer. It's spread, right? So from the surgical side of things, our real hope is to diagnose more and more early stage lung cancers, which is why we feel like screening is so important. There are a lot of symptoms that we look for with other cancers. For breast cancer, women are told to feel for masses. For colorectal cancer, rectal bleeding is a sign that something may be going on. But for lung cancer, that's just not the case. It's kind of a quiet thing until it isn't.
Wow. So tell me, what is the screening? I've grown up, here south of Louisiana, and I haven't heard much about it, and it just doesn't seem. You hear, go get this at this age, do that. Where does it start?
Yeah. So, and I think there's a few reasons for that. Number one is lung cancer screening is a little late to the scene. So this just sort of gained momentum after a study that was done in 2011. So while, that's 10 years ago and we should kind of be up to speed at that point, it's not as old as mammograms or colonoscopies. So I think it's gaining more momentum as people are learning more about it. But that's one reason, I think, is that it's a relatively new recommendation. The other reason I think a lot of people are unaware of it is I think there's a real stigma with lung cancer. One of the requirements to get screening, and I can go through that in a little bit more detail as well, is that either you're a current smoker or a former smoker who's quit within the past 15 years. So a lot of patients are not really proud of that fact about themselves. They're not excited to say, oh yeah, that's me. I've been smoking my whole life, especially when it comes to healthcare. There just seems to be some shame that goes along with that. And I mean, I reassure patients constantly, nicotine is addictive, and particularly, patients who are in the age range for cigarette smoking, they may not have even had, a realization as to the detrimental health effects of cigarette smoking back when they started. So I think getting over that bias, that stigma, is one piece of it. And the other piece of it is that we just need to be more vocal in spreading the word. So when we talk about who's eligible for screening, it's a huge patient population, particularly, here in my home state of Louisiana, right? It's a lot of people. It's patients age 50 to 80 who have either are currently smoking or have quit within the past 15 years and have what we call a greater than or equal to 20 pack year smoking history, which is a little confusing. So a pack year is packs per day multiplied by years smoked. So you can get to a 20 pack year by smoking 1 pack a day for 20 years, or 2 packs a day for 15 years, or, a half a pack a day for 40 years. There's a few different ways to reach that number. It doesn't have to be consecutive. We screen a lot of female patients who have stopped multiple times when they were having children, or male patients who have quit and gone back to it. But cumulatively, if you have 20 pack years and you fall within that age range, and you've smoked within the past 15 years, you're eligible for an annual low-dose screening CT scan. It's completely covered by insurance. There's no cost to the patient. And, unlike a lot of other screening tests, it's not invasive at all. You lay on a flat table, you go through a quick scanning machine. It takes a few minutes and then you're on your way. Not nearly as uncomfortable as a colonoscopy or a mammogram. So in all of the world of screening, screening tests, this one really is the most convenient and easy one. We just need to do a better job, I think, getting the word out there and letting patients know that, there's no shame in coming forward and saying, ugh, I'm high risk for lung cancer. I should come get this test.
No, I was trying to run the. I'm a former smoker, and so I was sitting there going, do I make it? And it's a huge number of people, and we're really not doing a great job. So currently, of all of the patients in our state who are eligible for screening, we're currently screening less than 4%. Wow.
So it's a grassroots effort. And as much as I feel like I'm, waving the sign in everyone's face, it's tough. It's tough to get everybody to understand how important it is to come in.
So I guess I get where I get hung up, and not to get into the weeds on this, but it seems like the age thing seems weird to me. Like, I'm not 50, I'm mid 40s, 40 something. It's like, okay, but I started, I quit around when we had the flood in 16. So whatever math that is. So, but it's like, I've been smoking for a long time.
Yeah.
It's like, but I'm not at the mark. Is it something like, does it metastasize? Is that the right word? Does, something happen, at 50, or is it like, no, just, it's an insurance number, where they're saying like, hey, that's where we're willing to cut it. So
it's definitely
somebody like me come in and go, hey, I'll do it.
Yeah.
Can I come and do it and just say, hey, can I write the check for it?
Write the check for it. Absolutely. But it's an insurance number. You're absolutely right. So they're looking at risk versus benefit. It's also, there's research that has gone into this to prove the benefit of screening. So the big trial that came out in 2011 was the National Lung Cancer Screening Trial. And so the patient population that they studied in that trial was patients age 55 to 74. So initially, that's what was approved for screening, just because that was the patient population that they chose for the study. It was relatively recently, just in the last year, that they broadened the age range. So they dropped, it was 55 to 74, and then some insurance companies were saying 55 to 77. And now the United States Preventative Task Force came out, I believe it was this past March, and broadened it even further to 50 to 80. So I think as they study this more and more, they'll be able to say, okay, well, we thought just patients over 55 were benefiting from this, but we dropped it to 50 and now we're seeing this benefit. So why don't we study this age group of 45 to 50 and see if there's a benefit there? It's all numbers. It's all risk benefit. How many are you catching versus how many screens you're doing?
Okay. So tell me, just if somebody wanted to, where do they go? You're not going into the ER for this.
Nope.
Do you need referral, for this, or? There's
a couple of routes you can go. So one is to talk to your primary care physician. They can order the test. It's very easy to order in the electronic medical record. So that's one route. If you have a primary care physician, if you have a pulmonologist, talk to them about it, see if you're eligible, and, ask them to order it. Most of our pulmonologists and primary care physicians should already be ordering this, but certainly if your doctor hasn't mentioned it, you should. The other alternative is just to call us directly. So we have a lung nodule coordinator who this is her whole job is helping patients, get the scans they need, get screened, all of those scans. Then if there's any significant finding, she brings that to our multidisciplinary team. And that's a team that meets weekly to review all of these CT scans in a conference room. We do it every Thursday at lunchtime. And we go through anywhere from 10 to 25 CT scans, that are concerning, so that we can make recommendations. So our nodule coordinator is able to kind of bring those concerning scans to conference, have the multidisciplinary discussion, bring patients in when they need to be brought in, or just notify them of their results, or their primary care physician if that's who's referred them. So we're working really hard to sort of make this a well-oiled machine and make sure that every scan gets the attention that it needs, and that every patient gets the attention that they need when it comes to, to interpreting those and planning scheduled follow-ups.
That works. So if we go from there, one of the things is this, this is lungs that we're talking about here. This has got to be a pretty big deal from the surgical side, right? And technology is changing and moving. Has that made any change, from before? Is it, still what we're seeing on TV, people surrounding, the patient?
It's made a huge change. So, the reason that surgery in the chest was always such a dreaded thing is because the traditional incision for lung surgery is a posterolateral thoracotomy incision. So a thoracotomy is a big, long incision between the ribs. the instruments just look scary, right? So there's spreading of the ribs. Sometimes there's breaking of ribs. It's not a difficult place to access. But fortunately, as minimally invasive surgery has taken off, and now we've evolved even into the robotic platform, we're now able to do lung cancer surgery through really small incisions. So our incisions are 8 to 12 millimeters, which is between, a third of an inch to a half of an inch. We have long, skinny cameras, long, skinny dissecting instruments. We're able to do the surgery more safely, with less pain, decreased trauma to the tissues. Patients are doing better. They're going home a lot earlier, and it's really not as big of an ordeal, I think, as it once was. Patients used to come into the hospital for lung cancer surgery, and they'd be in the hospital for weeks. They'd have this big incision. Wow. They would really be sort of debilitated for an amount of time moving forward. So I think this has really changed the game. And I think as we've gotten better with the surgical treatments for lung cancer, that's propelled the screening even further, because as the treatments get better, then we say, okay, we've got some really good options for early stage lung cancer now. What's the hurdle to diagnosing more of those lung cancer patients at the earlier stage, where we can really use, the tools that are in our tool shed to get rid of this lung cancer? And I think that that's a tough thing for people as well. I think there's definitely a feeling in the community. And like I mentioned, this is my community. This is my hometown. So, I get this from relatives all the time. The holidays are coming up. I guarantee you I'll have several aunts and uncles be like, you can remove lung cancer with surgery. And it's like, yes, that's what we do all day long. In its early stages, lung cancer is a survivable thing that can just be surgically removed, meaning, a stage 1A lung cancer typically won't require any chemotherapy, any radiation therapy. We just take it out with surgery, and that's it.
Really? And is that, for somebody who doesn't know, is that just removing the cancer, or is that like, do we take part of the lung with it,
Part of the lung with it, yeah. So it depends on the location and the size will determine how much lung needs to come out for a complete resection. Sometimes it's a lobe of the lung. Sometimes it's a segment of the lung. That's a judgment call once we diagnose a lung cancer, but it's a very successful surgery. And I think we've made it so much better than it used to be for a patient.
So, but the trick for anybody who's not paying attention is to get the screening done early before it gets to the point to where, hey, there's not much we can really do, because we'd have to take the whole lung, or both,
or it's not even necessarily, sometimes that's the case, right? Where the mass itself has grown to a size that it's no longer able to be removed with surgery. But the bigger problem is once it's spread outside of the lung. So lung cancer can spread to the brain, to the adrenal glands in the abdomen, to lymph nodes, just about anywhere, to the liver, so once it's in multiple organ systems, then taking it out with surgery doesn't offer as much of a benefit, because you still have active cancer in other places. So as the cancer spreads further and further, our options kind of start to become less and less to rid the patient of that cancer.
Well, this is good news, and it's bad if you have it, but it's good if you catch it early. So it's really, like you said, we've got to get the message out for people to try. Is the CT scan? I've done CT scans. It's easy, right? You said it. You lay down, you get scanned, you're in and out. Is this a long, big ordeal for people to? Is it fairly quickly to get scheduled? Is it like, is this I'm taking an afternoon off of work, or I'm gonna try to go run and do this during lunch?
No, I think you're going to do it during lunch. It's really easy. It is really easy. It's fast. We get them done quickly. Anything that we find that's concerning on a CT scan is always going to be presented to our multidisciplinary team within a week. So we meet weekly. So even if something is caught the day after we meet, it'll be worked up within a week on the next week's Nodule conference. So I mean, I think we're doing a great job being really expeditious and getting patients in and out quickly. We know it's a stressful thing for patients. We know, it's not something that you're excited about doing, right? Having your lungs looked at in 3 dimensions to try and examine every little thing. But it's just so impactful. And I've heard patients say time and time again, well, why would I do that? I mean, if there's something growing in there, I don't want to know because there's nothing you can do about it anyway. And I'll never take chemo and all of this kind of stuff. And I think that that's a big part of the message too, is no, there is something we can do about it. There's a lot we can do about it potentially, but we can't do anything about it if we don't know that it's there.
Yeah. What do they say? The first step solving a problem is admitting there is one.
Yeah, exactly. And because of the outward signs, you're just not going to know. I describe it to patients. I describe the lung as being sort of like a big sponge, right? It's a soft air-filled organ, so it's very spongy. So I mean, if you have a green pea in the center of that sponge, you're not going to know it. It's completely surrounded by a spongy air-filled organ. It's not going to cause you any problems. You're not going to feel it. It's not going to affect your breathing. Until it grows.
Is there, obviously we talked about the smoking and, makes it more of a high risk, but do you think, and this isn't by any means to knock or push, I have no problem, kind of in that, we live in the petrochemical industry. We've got guys, I've got family. I think everybody's got family that, works at a plant or, works next to the plant, should we be talking to those guys? It's like, hey, you really should, like, you may be at a higher risk because of, what you've been doing for the last, 30, 40 years.
Yes.
Yeah.
And that is in the screening guidelines. It's just a little bit more vague. It's not as defined. So I think insurance companies haven't totally bought into how to define what is high risk when it comes to environmental exposures. But it's certainly a risk factor. And I think when combined with cigarette smoking, it's sort of an exponential risk. So I think as more and more studies are being done and more research is going into this and we get more definition, I think that the screening parameters are just going to continue to get bigger and bigger and bigger. There's been a huge uptick just, within the 6 years of my career, there's been a huge uptick of lung cancer in middle-aged females who have never smoked. And so there's clearly a lot that goes into it that we don't completely understand the reasons for, right? I mean, I think, there's genetic factors at play. There's environmental factors at play. It's not a direct cause and effect, smoking equals lung cancer. There's a whole lot of gray area there. And I think as we increase awareness, as we utilize our awareness month to get people's attention, then hopefully, more and more dollars are going to be spent on researching these things because they're really important. I think lung cancer doesn't get nearly the attention it deserves. Both in our state and in our country, lung cancer is the #1 cancer killer. It's more than breast, prostate, and colorectal combined.
Wow.
It's huge. It's a staggering number of people that are dying every day of this disease. But it doesn't seem to get nearly the attention that the others get, and it's not just attention. That's probably not the correct word, but the awareness, the funding, the research, I mean, all of that is so, so important.
No, and I hope hopefully this will get somebody to either run in, make the phone call, or forward the show to somebody else, tell them to take a look, something hopefully would help with. But I don't know. It seems when you got an answer that's so simple, kind of, it's like, hey, just like you said, it's during lunch. It's make a phone call, go in.
Yep.
10 days later, you got some information, and it's the better thing to do. So,
it really is staggering. So I mentioned, going to the holidays with the family, and people are always asking about this sort of thing. So I've obviously encouraged numerous family members to go get screened. And a year ago, I convinced my aunt to go get screened, and sure enough, early stage lung cancer.
Wow.
So she had it removed robotically. She's doing great. And I'm like, gosh, if this can be happening just in my little family, because that's all it took. She just didn't know about it. It just took me saying, hey, you fall within this age group. You really should go get screened. Do it for me. I'm building this screening program. Come on, Aunt. Right. and I mean, we saved her life. It's incredible.
That's amazing.
It's incredible.
Well, I appreciate you taking some time. I always tell everybody you got more important things to do than talk to me all day. So I appreciate you taking a little time to fill us in, and hopefully, like I said, we can get some awareness out here for you, get people to think a little bit. This isn't, like I said, it's non-invasive. This is an easy answer.
It's, if you fall into that category, it's a zero cost, non-invasive. It's really simple. It's a no-brainer. Just do it.
Gotcha. Well, I appreciate it. We'll have to have you come back, tell us kind of maybe how things are going. We'll check in, some more. I appreciate it.
That sounds great. Thanks so much for having me.
All right. Thank you.